Hello, this is Siddharth Dambar. Welcome to our webinar today, talking about regenerative medicine in arthritis, tendinitis, and for injuries and back pain. Okay, great. Well, let's go ahead and get started. So my name is Siddharth Dambar, physician at Chicago Arthritis and Regenerative Medicine. Today's discussion is on regenerative medicine for arthritis, tendinitis, injuries, and back pain. I've got some material to go through, but please ask your questions as I'm speaking, and I'll go ahead and answer them as we're going along. What will you get from this webinar? You'll learn about the best available treatment for arthritis and tendinitis that do not require surgery using your own cells, what is legitimate, not legitimate in the field of regenerative medicine, and how to choose the best physicians and clinics for regenerative medicine and how to avoid problems. So what would you do if your pain was controlled? That's really the big question. How would your life improve? What exercise would you restart? And what activities with family and friends would you participate in? So who am I to be speaking about this? I'm a physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections, in practice since 2008, involved in regenerative medicine since 2008, also part of the Regenix Network, which is the largest network of physicians who are involved in regenerative medicine since 2012. In that network, we share standard operating procedures, results, and just really kind of a common approach to treating patients. My journey into regenerative medicine really started with my own shoulder. I played tennis somewhat competitively when I was younger. I learned musculoskeletal ultrasound during my fellowship back in the early 2000s. And at that time, I started to recognize that there's a whole lot of tendon and ligament injuries that really get underdiagnosed. And when we treat them, we don't treat them as well as we should. And so really just learning about my own body and my own kind of issues got me involved in regenerative medicine. The traditional care for arthritis and tendinitis is really insufficient. And that applies for arthritis, tendinitis, injuries, back pain, neck pain. Really, the traditional model of care is mask the pain and wait for eventual surgery. That's to compare that to other parts of medicine. It would be like if you you had diabetes, and instead of treating the diabetes at an early stage, you just waited until your diabetes progressed over time. Nobody would recommend that. Really a terrible way to treat people as well. So we do that same thing when it comes to orthopedic care, and it's my belief that we can do better than that. So problems with traditional care include the following. Pain medications don't fix the problem. They do have side effects as well that can be significant. Traditional injections, including steroid injections and nerve blocks, radiofrequency ablations, can help with pain, but they don't actually help with fixing what the underlying problem is. Other issues with traditional care, surgery is obviously appropriate in some cases, but we use surgery a lot way too early in the course of people's care, and that's a problem because there's higher risk associated with surgery than other treatment options. In addition, if you're cutting out tissue, you leave the joint more chronically unstable, which can lead to an acceleration of arthritis. And frankly, quite a few routine surgeries are not proven to be effective, whether that's using knee arthroscopy in the setting of existing knee arthritis. There are various medical journals that have documented that roughly 75% of orthopedic surgeries are done without the highest level of evidence. That doesn't mean that they're all not appropriate, but it means that a lot could be handled differently. And for those of us that are involved in regenerative medicine, really strong belief that 80% of conditions that are currently being treated surgically should and will be treated non-surgically in the future. So in searching for better options, there's a few keys. Number one, avoiding side effects. And these treatments should be low risk, improve the actual cause of the problem, and looking for solutions that are actually longer term in terms of giving results. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the practice of medicine where you use your own cells to treat arthritis, tendinitis, and injuries. In the normal healing process, take something as simple as a small cut on your finger. What happens is you have platelets that infiltrate the area. Those platelets release growth factors, which then stimulate your own mesenchymal stem cells, which then help the tissue to start repair itself. That's a great way to heal if your injury is recent, if it's mild, and if the organ has good blood flow. Unfortunately, tissues that don't have good blood flow, and that includes cartilage, tendons, disc, labrum, menisci, they tend not to have very good blood flow on their own. So once they've been significantly damaged, they don't tend to heal very well on their own. So regenerative medicine is a process of taking those same cells, your own either platelets or your own bone marrow stem cells, and then under ultrasound or X-ray guidance, injecting that into the tissue that's been damaged in order to help the tissue to recover. So why regenerative medicine? To begin with, it treats the source of the problem. It's safer than surgery. It's effective for most musculoskeletal conditions, and 80% of traditional orthopedic surgery will eventually be managed by regenerative medicine. So how does regenerative medicine work? A number of different ways. Number one, you can optimize damaged tissue. So what that means is that when you look in a joint or tendon that's been chronically damaged, what you have are cells that are no longer functioning well. And regenerative medicine helps those cells to start functioning better, which means they start producing the right proteins and enzymes that you see in a healthy joint or tendon. In addition, by injecting your own bone marrow-derived stem cells into tissue that's been damaged, you can actually get your existing stem cells in that area to start functioning better as well. All key to get a healthier joint, more stable joint, and less pain as well. In addition, we not only treat the joint that may be damaged or arthritic, but you end up treating all the other supportive soft tissue structures, whether it's ligaments, tendons, other soft tissue structures. By strengthening those tissues, you get an overall unit or joint that is stronger, which then helps with pain and then which helps with function as well long-term. In addition, we can help reduce chronic inflammation that you see in a joint that's arthritic or in a tendon that's got tendinitis. Also, you can also improve neuromuscular health. And what that means is in painful conditions, you do find nerves that are chronically irritated as well. We can treat those to then actually help reduce pain as well long-term. So a few kind of FAQs, and I see some questions coming through. To begin with, is this legal? Yes, there are very strict guidelines from the FDA, and the keys here are you using your own cells? The cells cannot be significantly altered or adjusted, and you need to inject them into damaged orthopedic tissue. As long as you follow those rules, then these are FDA compliant. So a common question that I hear is, if I'm older, shouldn't I use someone else's cells? And the answer is no. For the vast majority of orthopedic conditions, there's very good evidence that using your own cells is effective and the right thing to do. Keep in mind that when you use somebody else's cells, there's other risks. For example, your body recognizes other foreign tissue as well as foreign, and so it attacks it. And so by injecting somebody else's tissue into yourself, there's a risk of causing more problems, causing more inflammation, what's called graft versus host disease, and sometimes even infection risk as well. So stick with your own cells. Is there an age limit? With the exception of hips, there's really no other age limit. That means for knees, lower back, shoulders, elbows, ankles, and neck, there's no actual limitation based on age limit, at least based on the evidence that's been published. Hips are a little bit different, where age over 65 can make somebody a harder candidate. So what sort of doctor does these treatments? My strong recommendation is What works in medicine is that you work with people who specialize in what they do. There's just too much to learn and understand in medicine for any physician to really be an expert in everything. So, I recommend that you work with physicians who are focused on musculoskeletal conditions. You work with physicians who are focused on non-surgical treatment for orthopedic conditions. So, as an example, orthopedic surgeons are very good at surgery, but they don't get the training that's appropriate for these kind of treatments, namely using ultrasound and X-ray guidance. And then lastly, they should be a proper regenerative medicine expert, and I'll explain what that is a little bit later, where they understand the nuances of how to do these treatments, as opposed to someone who maybe takes the wrong approach to these treatments, which I'll explain later. So can these treatments help if I've already had surgery? I see somebody asked about if they've already had meniscus surgery. The shorter answer is yes, the exceptions being if the joint has already been replaced. One of the challenges if you've had, let's say, a meniscus that's been removed, is that the joint is overall more unstable long-term because of that. And so while we can't rebuild the meniscus in that case, you can help to improve stability by treating what's remaining of the meniscus and the other ligaments in that area as well. So the short answer is yes. My general rules for orthopedic surgeries are keep your anatomy, avoid surgeries that cut out tissue, and always consider a regenerative medicine treatment option if you've been recommended surgery. So great question. What are the risks? So the risks with anytime you stick a needle into the body, the risks are of bleeding, infection, tissue damage, and no response. So how do we limit those risks? Number one is you do procedures obviously under appropriate sterile medical technique. And that really essentially limits your risk of infection almost to nothing. Number two, you do all your treatments with ultrasound or X-ray guidance. The reason why you do that is, number one is you don't want to inject into tissue that shouldn't be treated. So that's how you reduce the risks. And you want to inject specifically into tissue that needs to be treated. And then lastly, it's a matter of really just picking the right candidates, meaning if someone has as an example, if you're treating a rotator cuff tear, if the tear is still relatively intact, the tissue ends, and that's still treatable. On the other hand, if the tissue is totally blown apart and there's a massive gap there, then that's more appropriate for surgery. Even in that case, a combination of surgery with regenerative medicine is a more ideal way to go. But a lot of it is picking the right candidates. So when we talk about regenerative medicine experts, there's three different things to understand, and I'll talk about each one of these. So stability is very key. There's a concept in architecture called tensegrity, which means that when you take an overall structure, the individual units are weak on their own, but when you put them close together under compression and arrange in a manner that is more stable, you lead to an overall more stable and functional unit. So in medicine or in biology, that's called biotensegrity. So when it comes to treating your joint issues, part of the key is injecting all those other soft tissue structures. And so that's called prolotherapy. Prolotherapy is a process where we inject your own cells into the ligaments and other soft tissue supportive structures to strengthen and stabilize the area. What's key to understand about that is if you have, let's say, for example, a arthritic knee, it's not enough to only inject into the knee joint. You need to treat the ligaments, the tendons, the muscles, the nerves, all those other tissues. You need to treat all those layers to get that depth of treatment. And what happens is you get a longer lasting result, progressive improvement over time, not just a quick result that wears off, but more of a longer enduring benefit over time, which then gives a longer lasting result as well. So case study, lower back pain, 71-year-old man who'd had prior surgery, L3 to L5 lumbar laminectomy. He's had 2 surgeries. He ended up getting platelet-rich plasma treatment. We ended up treating his ligaments, facet joints, muscles, and epidural space, really emphasizing treating all the different layers that are involved. His initial improvement was about 30%. We ended up escalating to using his own bone marrow-derived stem cells. He's now at a 75% improvement. He's 3 months or 3 years out from treatment and still doing well. Okay, great question. Will this work if you have rheumatoid arthritis? The way that I approach a condition like rheumatoid arthritis, and realistically, I'm probably one of the few physicians that understands how to treat a condition like rheumatoid arthritis, which is inflammation, and then still utilize these kind of regenerative medicine treatments. And the keys are, if you have an overall condition that's really hyperactive, if you have, let's say, 20 plus joints that are inflamed, I do recommend getting that under control. Frequently with medications, sometimes with dietary and supplements, but really trying to get the overall system under control before using some of these treatments. On the other hand, if you have overall inflammation is controlled, but you have more inflammation in, let's say, one or two joints, then I think utilizing regenerative medicine can still be helpful in that case. So it really depends on the individual that's being treated. Okay, I see a question about stem cell injections and FDA approval. We already talked about that, about how this is FDA compliant, which is why Regenix Corporate actually has about 600 companies that currently have these treatments covered by insurance. So orthobiologics, those are the biologic cells and tissues that we utilize during treatment, primarily using your own platelets or bone marrow stem cells. And again, this utilizes the normal healing cascade, and important that you use your own cells rather than somebody else's cells. So we talked about how the normal healing process, platelets get involved at a very early stage to help via inflammation and stimulating your own local stem cells to help with repair. There's a couple different types of platelet preps that we use. The main key here is that if you look at the figure, or if you look at the picture on the right, what you'll understand is that those are both platelet preparations, but the one on the left that's amber or yellow colored is the more appropriate one for your own platelets. And the reason why is because we've taken out the red blood cells. The one on the right, which has the red colored cells, that has too many red blood cells and will cause too much inflammation and can be damaging to the joint. Unfortunately, most physicians who are utilizing something like platelet-rich plasma don't understand what they're actually injecting. And part of that is because they don't have any flexibility to creating a platelet preparation or cell preparation that is ideal for you. And that's key because when you're treating joints or tendons or nerves or ligaments, each one of them deserves a slight different concentration of how you do this. And it's one of those really kind of subtle details that if you're focused and expert in this, you understand the difference. If you're not, you don't really focus on those kind of details. So the next example is a 45-year-old man who's a cyclist. He presented with left knee pain. He was referred by a sports medicine physician for patellar tendinitis. And what he ended up having was platelet-rich plasma. And I'll show you what that looks like in a moment. So the picture on the right is an example of platelet-rich plasma. And just draw a little bit here. This is the tendon. This is the bone. That's the needle. Key to understand that we're really trying to very precisely inject, in his case, his platelets into the tendon injury. He had 2 treatments and was able to get back to his full capacity in terms of exercise and training for his triathlons. 3 years later, he presented with the other leg. Now he had a hamstring strain. Again, platelet-rich plasma, and again, he did great and is back to full activity. So keys there are treating this under ultrasound guidance, treating multiple times to get a better result, and then an ability to treat other things because platelet-rich plasma typically does work pretty well for soft tissue injuries. Okay, lots of good questions here. Okay, somebody asked about bone plasma platelets. I think you mean either platelet-rich plasma. Platelet-rich plasma comes just from a blood draw. Bone marrow stem cells come from a bone marrow aspiration. I can tell you that at least for my patients, when we do this, on average, they tell us discomfort with that is a 3 out of 10 pain. We don't knock people out for that routinely. It's an option, but we don't recommend it routinely. Normally just using a lot of local anesthetic and good technique is what it takes to get people comfortable and appropriate to do this. Okay, another good question. What about knee replacement where you don't have any cartilage in the knee area and you have bone on bone? So we're going to talk about that in a little bit as well. But simple answer is it depends on which joint we're treating, but knees tend to respond very well. If you have more advanced arthritis in the knees, using your own bone marrow stem cells is a great option. And the evidence shows that you can still get an average or better response in that kind of scenario, meaning a 65% or better improvement. So the next type of cell type to know about for regenerative medicine are your own stem cells. This is the main cell that drives tissue repair and recovery after an injury. Always use your own cells, always, always, always. There's risk when you use somebody else's cells. In addition, what is legally allowed in the United States for stem cell treatments are utilizing your own bone marrow derived stem cells. That is what's legal. If your physician is using fat stem cells, that is not legal in the US. And the reason why is because the FDA has concerns that part of the preparation process is to use an enzyme that they think may not be safe in humans. You can use fat as for structural support. And so we will on occasion utilize adipose or fat to augment a bone marrow stem cell treatment by offering more connective tissue and support. But strictly speaking, fat is not a stem cell treatment. You may hear about amniotic or umbilical cord cells that used to be very popularly advertised. There are no living cells in that. The way that those cells are processed to be delivered to the physician's office results in no living cells. Multiple organizations have shown that, and the FDA and the FTC are basically cracking down on clinics that are utilizing amniotic and umbilical cord cells and claiming that it's your own, or claiming that they're stem cells, because that's not accurate. You may occasionally hear about IV stem cells. There's no evidence that benefits orthopedic conditions. I do not recommend that. The vast majority of data is really just injecting your own stem cells or platelets directly into the joint. Yeah, good question. You're saying your own body is best medicine. Yes, ideally, yes. Reality is that there's some conditions where maybe you need surgery or medication, but anytime you can use your own body's healing process, always better, lower risk, more, it's the normal way of healing. And so that's always preferable. So in terms of stem cell treatment outcomes, here's some things you should know. Improving pain and function is absolutely possible even in advanced cases. And the reason why is because we can improve stability, improve inflammation. You can improve the cells in the joint that have been chronically damaged. That will result in improved exercise tolerance, which on its own helps with strength and function as well. Can we improve how your x-rays and MRI images look? If you've got advanced arthritis, no. And so if your physician, chiropractor, or advertising is showing x-rays to show an improvement, that is, unfortunately, that is fraudulent. That is not really legitimate. That cannot happen. If you have tendon or ligament tears where the injury is still amenable to treatment, then yes, you can get those to start to get closer to look back to normal. If you have swelling in the bone in arthritic joints, we can improve that. If you have a condition called avascular necrosis, we can improve that as well. So there are things that we can improve on imaging, but when it comes to more advanced arthritis, it's more about improving pain and function. So here is a question: can we treat bone-on-bone arthritis? Simple answer is yes, but it also depends on what condition we're treating. So if we're treating advanced arthritis in the knees, the evidence shows that you can still get a good outcome, and a good outcome would be a 65% improvement in pain and function at the 1 and 2 year mark. Because you need to understand that that term bone-on-bone arthritis is really not correct. If you're able to still bend your knee through an almost normal range of motion, you don't have bone-on-bone. You have arthritis, which is a biologic condition that is still treatable with regenerative medicine treatments. Hips are a little bit different. That is more challenging. And so that's a caveat. But expectations in general, if you have more advanced arthritis, is improving pain and function. However, improving imaging is unlikely. Okay, so great question. Somebody asked, Do we check x-rays to determine if the knees are damaged enough for this procedure? Yes, absolutely. Sometimes we'll require an MRI as well, but absolutely imaging is helpful. We asked about what about knee replacement where you don't have cartilage and it's bone on bone. So we talked about that. My recommendation is knowing that knees tend to do very well with treatment. I would recommend in the case of someone who's got significant arthritis, I would strongly recommend that you consider one of these kind of treatments. Somebody asked, for people who've lost range of motion, it depends. Can these treatments help if you've lost range of motion? It depends. I think if you've lost range of motion, it reduces how well you can do. But sometimes, for example, in knees, your range of motion may be limited because you've got chronic swelling in the knee. And the key is to stabilize the knee, reduce the chronic inflammation, and range of motion improves. May not get back to normal, but I use range of motion as one variable, but it's not the only thing on its own. Okay, there's some questions about insurance. We'll get to that in a moment. This is an example of, when people ask, can you treat ligament tears? This is an example of someone who has a knee ACL injury. This is a 28-year-old man playing recreational volleyball. He's actually a butcher. He had an injury. We treated him basically 2 months after his injury. And, within 3 months, he was not only functionally doing well, but, he had a really great response in terms of outcome as well. So on the right side, this is your knee. That's the kneecap. This is the needle. And this is the anterior cruciate ligament. You can only do this kind of procedure under X-ray guidance. And let me show you what his outcomes look like. So this is a great MRI to show how some of these things can really improve. The MRI on the left is after his injury, before his treatment. This is the ACL down here. And you'll see that there's just a very hazy mass up here. That is a significant injury to the ACL, which is why it's very hard to see. The picture on the right is the ACL, and now you have a very nice, clear, linear structure where you can really make it out much better, which is after treatment. And so he had not only a great response with pain relief and functional improvement, but a great imaging response as well. This is a case of a rotator cuff injury. This is a gentleman, he's a contractor. He had chronic rotator cuff kind of pain, shoulder pain for a while, pain with overhead activity. This is an ultrasound image. This hole right here, that is where the rotator cuff tear is. And here it is on the bottom as well. On the right side, this is 3 months after treatment. And now you see that hole has filled in. So again, he has improved pain, improved function, and really nicely, he's also got an improvement in how his MRI looks as well. Interventional orthopedics, this is the concept of using X-ray and ultrasound guidance to treat orthopedic injuries. Really important because I have colleagues a little bit older who claim to be able to inject joints and tendons just blindly, just by palpating the skin. And for these kind of treatments, that's just not possible. As an example, this picture that just popped up, this is an example of a rotator cuff injury where we had to inject at a very, very kind of detailed spot. So here's a needle, here's the rotator cuff. His injury is very small. It is a less than 1 centimeter by 1 centimeter spot. And so to inject that, you need X-ray guidance. On the right, this is an X-ray image. This is the needle. This is the shoulder joint. We're injecting, and what's lighting up here, the black structure, that's the joint, and lighting up here is the labrum. So we're injecting structures that are deep and very, that really require a lot of precision. And as I tell patients is, I can't do this blindly. And until I have X-ray vision, I'll be using the tools that we have in clinic. And these are pictures that we showed before. On the left was injecting into patellar tendinitis, and on the right is injecting into an ACL. Things that you can really only do competently with image guidance. If your physician is not using image guidance, then you're not getting the right treatment. It's another nice case study. It's a gentleman, he's a chef, stands on his feet for about 12 hours at a time. He had wear and tear arthritis. He also has what's called avascular necrosis. This picture on the right here, the left, but this is his pre-treatment MRI. What's lighting up here is avascular necrosis, damage to the bone. And this is his image on the right where the avascular necrosis has resolved. He's doing really fantastic, 3 years out from treatment, and is able to stand on his feet for 12 hours on end at work. And just a great imaging result, but more importantly, great clinical result in terms of pain and functional improvement. Regenerative medicine treatments offer safe and effective solutions for your pain. So some other FAQs, and I'll get to the other questions that have come through. Is this too good to be true? So there's data going back to the mid-90s from a physician, Philippe Hernegue in France, for using in knees and shoulders, using your own bone marrow stem cells. In the Regenix network, there's data that goes back to 2005. Understand that this is a rapidly developing field, but it's not new. My personal experience has been since 2008. There's definitely right and wrong ways to do this. Your expectations should be grounded in reality and evidence-based medicine, but absolutely, this is the right way to treat most orthopedic conditions. How long do results last? So Regenix has data that goes over 10 years. Philippe Hernegue has data that goes over 20 years. I always recommend to people, be a little bit conservative in your expectations. And, for chronic conditions, expect that somewhere down the line, a few years down the line, you may need a repeat booster treatment to keep your initial result at a very high level. The best way to maintain results after treatment are to improve your biomechanics with physical therapy, take the appropriate supplements, and if needed down the line, get a repeat treatment to keep that initial treatment going well. All right, cost. So number one, for the vast majority of people, these are still not covered by traditional insurance. Regenix Corporate has roughly 600 companies in the United States where they've added these treatments to their benefits plan, where it is covered by insurance, 600 companies. So if you're interested in that, I'd recommend going to regenixcorporate.com to see if your company's on the list, or if you'd like to talk to them, Regenix, about having your company added to this list. If it's not part of the Regenix corporate plan, the cost estimates in the US, which you should expect to see to begin with, are roughly platelet-rich plasma goes for $1,500 plus for one joint, and for stem cell treatment, $7,500 plus for one joint. What I recommend is the keys to determine are you getting good value are the following. Number one, is the physician you're working with and the clinic that you're working with, are they true regenerative medicine experts? They know what they're doing. And by that, I mean, if your physician is treating, giving Botox for wrinkles on the side, and is giving testosterone hormone supplements in another room, and then happens to be injecting your knee or back on the other side, they're probably not an expert in regenerative medicine. And I'd recommend avoiding that. Find somebody who's really focused on just this. In addition, are you receiving a real stem cell treatment from your own cells, or are you getting a bogus amniotic or umbilical cord product that's been mislabeled? If that's the case, then you're not getting good value. And then, understand that these are in-office procedures. You do not need to go to a hospital. You do not need to go to a surgery center for facility fees. The office you should go to should have a proper setup, meaning they should have a proper procedure room. They should have the proper equipment to do the procedures in terms of X-ray and ultrasound guidance. They should have a crash cart. They should have a physician who's doing these procedures, not a mid-level, not a physician assistant or nurse practitioner. They should have trained nurses on staff to help you out as well. They should be doing this properly. They should not be cutting corners, but these do not need to be done in the hospital. You can do these appropriately and safely in the office if you're working with proper professionals. Just a little bit more about Chicago Arthritis, Regenerative Medicine. Our approach is as follows. We are focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. We start by evaluating the big picture, meaning inflammation, instability, asymmetry, nerve-related issues. We try to correct with low-risk interventions where possible. If not working for wear and tear arthritis, tendinitis, injuries, and back pain, we'll then recommend a regenerative medicine treatment. And when we do, we're recommending using the best quality products from your own body, a plan that is very specific to your condition and not just a one-size-fits-all process, and delivering cells utilizing the highest level of imaging guidance. Great. I'm just scrolling through to see if there's any questions I missed. How to get evaluated? Simplest way is to go to chicagoarthritis.com. Well, wonderful. Okay, somebody asked about cost of evaluation. Cost of evaluation should be covered by your insurance. So the only parts of this process that are not covered by insurance are the procedures. When it comes to the cost of evaluation or with the physician or with x-rays, MRI, physical therapy, any bracing, anything else that's needed, all that should be covered by your insurance. If you don't have insurance and you need you're paying this out of pocket, just email us and we'll give you an appropriate cash price to make this reasonable. Great question. How soon will you see treatment results after treatment? Great question. So these treatments are different than, let's say, a steroid injection. If you get a steroid injection, you'll have some relief after a day or so, and that'll last for a few weeks, and then it starts to wear off. These treatments are very different. You're going to have more inflammation up front for the first 2-3 days, stiffness for the first week or 2 weeks, and then at around the 3 to 4 week mark, you'll start to notice difference, and then it'll progressively get better for the next 3 to 6 months. And that improvement will then last longer term as well. And your improvement will start slowly, meaning you'll start to notice, hey, I'm using a little bit less pain medication than I was before procedure. Okay, that's interesting. Going upstairs, I'm able to do that a little bit easier and it's not hurting as I'm going upstairs. Or, you know what, I was walking the dog and, normally my back is hurting at the end of it and, I'm not really noticing that any longer. Like you start by getting very small improvements, and progressively over time, you start to notice more bigger improvements. But the expectations are high with these kind of treatments, but there's a little bit of patience required initially as your body is starting the healing process. Good question. Well, okay, great. Great question. Does platelet-rich plasma work on a herniated disc, L1, L2, or would stem cell treatment be needed? Great question. For lower back issues, I generally recommend platelets firsthand. And the reason why is because most of our patients do pretty well with just platelets. And the keys are to treat everything that's driving pain. So normally I would not recommend injecting into a disc early on, because you can normally treat just by treating the epidural space, the ligaments, facet joints, and for the vast majority of lower back patients, they do fine with that. Indications for when you would escalate to stem cell treatment would include the following. Number one is if we needed to inject into a disc. Number two would be if platelet-rich plasma was not giving you quite enough treatment, like maybe you're getting 30 to 40% improvement and you're trying to get more to 80% improvement. Or if you've had surgeries that have been pretty wide open in the past and you have more instability, when maybe stem cells would be a better option than just platelets. It's a great question. Well, I am slowly going to start wrapping up here. If you have any other questions at this time, please go ahead and type that in. If you have questions after we're done, please email us anytime with those questions. Our email address, which I'll just type in down here. If you'd like to set up an appointment, you can do so either by emailing us or by going to the office or by going to the website to do that. Good question about where's the office located. We're located in the West Loop in Chicago. That you just listed that address down there. And if you have additional questions, you can always contact us anytime. You know, our goals are to help to guide you here, whether that is evaluation or treatment with us or elsewhere. You know, we're here to educate first and to help out in any way possible. So if there's no other questions, I appreciate everybody's time. Hope everyone is doing well. You know, if we can help out in the future, let us know. And until we connect again, have a good day and live well. Thank you. Bye-bye.